is the role of surgery in heart failure minus the cardiac transplantation, but one has to take into cognizance the fact that the mainstay and the gold standard of therapy, definitive therapy for end-stage heart failure is cardiac transplantation or destination therapy in terms of left ventricular assist device or artificial heart. Now we all know that there is an increasing prevalence of end-stage heart disease and because of the various factors like aging population and the better treatment when the patient presents in acute myocardial infarction, there is a primary PCI, and gradually there is left ventricular remodeling which can lead to failures of heart, symptoms of heart failure. Now there are certain building blocks in heart failure management. Initially, as we have seen throughout yesterday and today, that the initial therapy is of course medical therapy and optimal medical management, followed by sometimes there is a role of electrophysiology therapy. If the patient is having malignant or ventricular arrhythmias, one can implant an ICD, AICD, followed by if the patient has got significant widening of QRS complex more than 1/52 left bundle branch block, then he can benefit with a cardiac synchronization therapy. Thereafter comes the role of VAD, a ventricular assist device, and the case of last resort, of course, is the cardiac transplantation. Now the heart failure can be treated in various stages. In stage D, suffices to say in a nutshell, in a refractory heart failure, the definitive treatment is cardiac transplantation. But one has to remember and one has to take into cognizance that transplantation is not a socially and economically logistic operation in our country, and most of the patients, they cannot afford transplantation, and most of the society is not accepting transplantation. So despite when we started our transplant program in 1994 in All India Institute, it has not had any exponential growth. It is carrying on but not exponentially. But worldwide, if you see the scenario of transplantation, there is a 10 to 15% negative growth of transplantation, whereas the VAD therapy is increasing. But again, the VAD therapy is not very popular. Hardly few dozens of VADs have been done in this country because of the expenses of the therapy. And taking cognizance into all these factors, one has to see that in ischemic cardiomyopathy, almost studies have shown that 50% of the patient will have a viable myocardium and can benefit for revascularization. So in a heart failure therapy, in a surgery for heart failure, you have to just remember three things, three V's rather. One is vessel, that is the coronary artery disease. One can treat the coronary artery disease. Second is the valve. You can do a valve repair or a valve replacement. And third is the ventricle. That means you can do a surgical ventricular remodeling. So when you manage these patients of heart failure, basically we need to manage in a system of a multidisciplinary team, where the team interacts actively with the patient and first assesses the patient, whether the patient can be recuperated, whether there can be a recompensation which is possible. If it is not possible, then it is better to give an end of life care, a comforting care. However, after assessment, if it is anticipated that some benefit can be accrued to the patient and recompensation is not tenable, it is not viable, then in that case the patient goes to the transplantation pathway, and this transplantation pathway can be trepided in various steps, where can be bridge to transplantation or destination therapy or cardiac transplantation, or it can be that patient can be offered another surgical treatment which can be treating the ischemic cardiomyopathy part in terms of either a medical therapy or a PCI or a surgery. The treatment for pump failure, a surgical therapy will be like a surgical ventricular restoration, and sometimes anti-arrhythmic therapy. So what are the surgical strategies in heart failure? Obviously, previous speakers have spoken about the mechanical heart, mechanical support, mechanical circulatory system. The cardiac transplantation will be spoken by Dr. KRB after me, and I am going to be sandwiched in between the two, which means I am going to address only the three V's apart from myself. So one is a vessel, which is coronary artery bypass surgery. Second is a valve repair or replacement. Now most of the studies have actually shown that there is no role of a valve repair, because basically if you have a patient of a coronary artery disease with a severe MR or grade 3, grade 4 MR, then the life expectancy is usually around 50% over 5 years. So most of the bioprostheses, current generation bioprostheses, they provide a lifetime of almost like 10 years. Their longevity is about 10 years. So there is no factual benefit of valve repair, because it has been found in various studies and various data that we have shown that failure of a valve repair carries a very high mortality, and hence now the trend is towards valve replacement, of course preserving the subtensor apparatus in order to preserve the LV function. Then there are certain other anecdotal therapies like myocyte restoration. I would call it anecdotal because I am not a great believer of stem cell therapy. We have tried it for over a couple of decades, but it never worked. Then there are certain historical procedures like cardiomyoplasty, like ACON, myosplint, or dynamic cardiomyoplasty. So what are the surgical options in an advanced heart failure? Now, first thing, when a patient, as I told you again, that most of the patient of end-stage heart failure with ischemic cardiomyopathy, almost 50% of the patient will have a viable myocardium, hibernating myocardium. In that scenario, you should offer a CABG, a high-risk CABG, which can be in tandem with a preoperative or intraoperative intra-aortic balloon support. The second category is you have significant mitral valve regurgitation, where grade 3 and grade 4. Actually, the rule of thumb is that if you do a quantitative analysis, echo analysis of the mitral regurg in obviously in a conscious state, not under anesthesia, because in under anesthesia the mitral regurgitation will be underestimated. If the regurgitant fraction is more than 50% than the forward LV ejection fraction, that patient should be always offered a mitral valve replacement or a repair. And the third thing is that if you have a significant anterolateral scar, or if you have a significant posterior scar, you can do a surgical remodeling of the ventricle in terms of a remodeling operation like DORS procedure. Now, it has been shown that the ischemic cardiomyopathy, which is treated with the revascularization strategy or revascularization for repair strategy of the valve repair, has got the similar type of survival as cardiac transplantation, of course minus the downsides of rejection, immunosuppression, and the economics of transplantation. Now, what are the current indications of SVR? Although there was a trial called STITCH trial, and STITCH trial has actually proven that there is no benefit of an additional procedure in terms of longevity and quality of life. But there are, however, many believers, because there are a lot of critics of the STITCH trial that it was not designed properly, and it was not, the criteria were not conformed. So there are many believers who still do a surgical ventricular restoration. I am one of them, because doing nothing is better doing something for this patient who have intractable heart failure and who come with congestive symptoms by pure surgical revascularization. So symptoms of heart failure: prior anterior wall MI, left ventricular dysfunction, especially ejection fraction less than 30%, and dilatation, left ventricular end diastolic volume index more than 100 ml per meter square, then regional LV kinesia and inducible ischemia. They are the cardinal indications for surgical ventricular restoration. And what is the relative contraindication? Is a severe PAH not associated with mitral regurg. An absolute contraindication is obviously a severe right ventricular dysfunction, severe regional asynergy without ventricular dilatation, and restrictive diastolic dysfunction, because one has to remember that in a surgical ventricular restoration, basically you are also causing a diastolic dysfunction. So inline diastolic function is a contraindication for SVR. How it is done? It's not a very complicated thing. No rocket science. You just open the scar, which is mostly anterior. You identify either visually between the scarred area and the viable area. Initially, we used to put what is known as a circular stitch in order to reduce the neck of the aneurysm, which is called a Fontaine stitch, but no longer is in put. Previously, we used to put a patch like a Dacron patch or a Gore-Tex patch. No longer we use it. We use only bovine pericardium. Results are consistently good, and most of the patients, surprisingly, they do quite well. Now, obviously, the Alex has already spoken about all sorts of ventricular assist devices. I will not dwell into detail on these ventricular devices. Suffice is to say that currently the only generation of devices available are called continuous flow devices. Previously, they were pulsatile. They are out of vogue. They are gone, obsolete. Now it is a continuous flow devices. It has got two kinds of mechanism of driving the flow. One is the axial flow devices. Example is HeartMate 2, and then the centrifugal devices, which example is maybe a HeartMate 3 as well as hardware. The important thing is that the important thing to understand is that in the axial flow devices you need a ball bearing, whereas in generation 3 devices you have magnetic levitation, so you eliminate the ball bearing. The upside is that once you eliminate the ball bearing, your chances of thrombosis, thromboembolism and hemolytic complication are obviously less. This has been talked in detail by the previous speaker. So the only interesting thing is that amongst the devices there is a new generation of a device which is coming, which is still under research and which has generated quite a lot of interest among the medical community. This is known as, possibly will be named as the Neptune. It is under research in Paris, France. It is based on a premise that a 100-ton whale, 100-ton shark can attain a speed of 120 miles per hour in the sea. So it is based on the physiology of shark fin motion, and this is the device which is eagerly waited. Maybe 2022 this device will be available. So I am not going to talk in details regarding this HeartMate 2 or hardware device. The fundamental difference between HeartMate 2 is that HeartMate 2 is a extra pericardial device. You need a pre-peritoneal pocket for that, and HeartMate 3 is an intra-pericardial device you can put right upon the heart. This is a HeartMate 3 device. This is a myosplint where you put a button and basically you restrict the heart rather than dilating, because in order, as you know that according to law of Laplace, the more is the tension, the wall tension is directly proportional to the radius of the curvature. But these are all anecdotal and these are all historical. They are nowhere it is practiced. This is a dynamic cardiomyoplasty. You take out the latissimus dorsi, you put over the heart, and then you pace the latissimus dorsi as if to augment the heart for its systolic function. Thank you very much.